Rotational atherectomy, commonly known as rotablation, is a percutaneous coronary intervention technique used to modify heavily calcified coronary lesions prior to balloon angioplasty and stent placement. Introduced in late 1980s, it has remained a vital tool in the drug-eluting stent era for lesions that are undilatable or uncrossable with conventional balloons. Rotablation works on the principle of differential cutting. A diamond-coated olive-shaped burr is advanced over a dedicated 0.009-inch guide wire and rotated at high speeds, typically 135 to 180,000 rpm, by a gas-driven turbine. Because the burr is abrasive rather than a sharp blade, it selectively pulverizes inelastic calcified atherosclerotic plaque into microparticles smaller than red blood cells that are washed away harmlessly by the microcirculation. It leaves adjacent elastic healthy tissue unaffected because normal tissue deflects away from the spinning burr. While early trials like Cobra and Stratas evaluated rotablation as a primary debulking strategy, its modern role is strictly for plaque modification to facilitate optimal stent expansion. It is indicated for heavily calcified lesions that cannot be crossed with a balloon or microcatheter, undilatable lesions where high pressure balloon inflation fail to expand the vessel, ostial lesions or severely angulated segments with significant calcium burden, stent underexpansion in specific off-label scenarios where conventional methods fail. Recent randomized controlled trials have focused on how best to use rotablation alongside modern drug-eluting stents and specialized balloons. Rotaxis trial 2013 randomized 240 patients with complex calcified lesions to standard balloon predilatation versus rotablation followed by stenting. The trial found that rotablation resulted in higher acute procedural success, 92.5% versus 83.3%. However, it did not show a long-term reduction in clinical events and was associated with slightly higher late lumen loss at 9 months. Prepare Calc trial 2018 compared lesion preparation using modified balloons, cutting or scoring, versus upfront rotablation in 200 patients with severely calcified lesions. Rotablation demonstrated superior strategy success, 98% versus 81%, primarily because 16% of the modified balloon group required crossover to rotablation due to uncrossable or undilatable lesions. Both strategies yielded comparable final stent expansion on optical coherence tomography. RotaCut trial 2024 investigated whether combining rotablation with cutting balloon angioplasty would yield better stent expansion than rotablation followed by non-compliant balloon angioplasty. Randomizing 60 patients, the trial found no significant difference in the primary endpoint of minimum stent area by intravascular ultrasound, 6.7 square millimeter versus 6.9 square millimeter. Both strategies proved safe and effective with minimal 30-day complications. Operators generally utilize a pecking motion, gentle advancement and retraction to prevent the burr from lodging and to allow continuous blood flow, which cools the device. A continuous flush solution containing lubricants, vasodilators like nitroglycerin and sometimes verapamil is used to prevent vasospasm and clear debris. Potential complications include slow flow or no reflow phenomenon caused by microvascular obstruction from calcific debris or thermal injury, vessel dissection or perforation. Risk increases with oversized burrs. The recommended burr to artery ratio is 0.6 or less. Transient AV block, common during ablation of the right coronary or dominant circumflex arteries. Temporary pacing may be required. Burr entrapment, a rare but severe complication requiring surgical retrieval if it cannot be freed.